Welcome to this talk from saferinsulin.org. There is a strong link between hypoglycemia and outcome in critically ill patients. Let's look at how to prevent, recognise and treat this avoidable complication. We all know what it feels like to be hangry, that feeling on a busy shift just before lunchtime when we feel tired, irritable, lethargic, and your brain just seems to slow right down. Have you considered what it feels like to have a severe hypoglycemic episode? If you've ever talked to a person with diabetes who's had frequent hypos, they will tell you just how awful it feels. As blood glucose drops below 4 millimoles per litre, symptoms include confusion, tiredness, sweating, and agitation. By the time the glucose drops below 2.7 millimoles per litre, what we would define as severe hypoglycemia, they can collapse into a life-threatening coma and seizures. What we can't see directly in that person is the knock-on effects of this later on their physiology, with the release of hormones such as glucagon, cortisol, growth hormone and adrenaline and noradrenaline that can affect their response to insulin and glucose control. It is well recognised that one hypo in a diabetic can predispose quickly to a subsequent hypos in the next 24 hours. Whilst these symptoms may be very obvious to a person with diabetes who deals with them regularly, and the signs may be obvious when someone presents typically to a medical professional when healthy, let's consider what happens to a person with or without diabetes who has a hypo in critical care. The first major challenge is that many of our patients are sedated or so unwell that they are unable to communicate their symptoms, and the signs of hypoglycemia are often hidden in patients who are critically ill, who may be sweating, tachycardic, or unconscious anyway. This means that if we are not vigilant and actively checking, the first evidence we may have is a dangerously low blood glucose level on a routine blood glucose check. The brain is critically dependent on glucose from the blood for its metabolism, and even short periods of severe hypoglycemia can result in catastrophic neuroglycopenia, irreversible brain damage, coma, and death. Despite readily available monitoring, causes of irreversible brain damage from hypoglycemia tragically still occur in hospitals and intensive care units. Even when measurable brain damage does not occur, the physiological consequences of episodes of hypoglycemia on the body's endocrine, cardiovascular, and other organ systems may have significant impact on that person's ability to mount a response to critical illness. To survive sepsis, major surgery or trauma, these patients need to mount a sustained metabolic, cardiovascular and immunological response for many days. We know that a hypo can have adverse effects on the release of stress hormones that last for many hours or even days after a single hypoglycemic event. We also know from large studies in critical care that episodes of hypoglycemia are associated with an increased risk of death. These findings have been shown repeatedly, and in one large study it was demonstrated that a patient in critical care's chance of dying increased significantly with the number and severity of hypoglycemic episodes. In other words, the more hypos your patient has and the lower they go, the less likely they are to survive their critical illness. Whilst it's important to acknowledge that this is a correlation and that it's difficult to attribute causation from studies like this, it should focus our attention on hypoglycemia in ICU. We know that patients who are more likely to die from multi-organ failure, liver injury and other conditions like shock often develop hypoglycemia as part of their clinical syndrome. So picking out a causal link from these big studies is challenging. However, it's clear from those individual cases of severe neuroglycopenia leading to clinically apparent brain injury that the harm that hypoglycemia can cause. And whilst most hypos happen without measurable long-term effects, given the physiological effects of hypoglycemia and the need for a patient who is critically ill to mount a supranormal physiological response to their illness, it is plausible that a hypoglycemic episode in our patient may directly impact on their chances of surviving their critical illness. We should do what we can to minimise the risk of iatrogenic harm when attempting to control blood glucose in ICU. We may never be able to reduce the risk of hypoglycemia in ICU to zero, and many hypos occur in patients who are not on blood glucose lowering medications. IV insulin is well recognised as a high-risk medication in ICU with frequent reported drug errors. In fact, it remains one of the most frequently reported. Whilst it's important for us not to ignore spontaneous hypoglycemic episodes that may be caused by prolonged fasting or liver failure, our main focus is on targeting the risk factors for iatrogenic hypoglycemia, an area where we can reduce avoidable harm. So what are the risk factors for iatrogenic hypoglycemia or critical care? Our audits of glucose management have repeatedly shown simple errors that if avoided, could significantly reduce the risk of harm. Number one is the failure of the team to notice and raise concern when a patient is on very high doses of IV insulin, often in order to control hyperglycemia when there is significant insulin resistance. Nurses and doctors can sometimes fail to acknowledge how abnormal and dangerous being on 10 mL an hour of IV insulin is. Secondly is monitoring. Most of the hypos we've seen on IV insulin are because the team have failed to adhere to the standard of hourly blood glucose checks when on a variable rate insulin infusion. Another area is a lack of recognition when a patient's blood sugar is falling but still within the normal range, a concept we call looming hypoglycemia. Historically, we've seen many hypos resulting from gaps in nutrition, such as a displaced NG tube or feed being stopped for transfers or operations, resulting in a sudden drop in blood glucose if the insulin isn't switched off. Another dangerous time is when patients are recovering from their critical illness and are transitioning back onto long-acting subcutaneous insulin. And lastly, a major risk factor for hypos in ICU is administration of insulin dextrose to treat hypotassium. It's really important that we recognise that insulin is a high-risk drug in high-risk patients. It's used so commonly in hospitals that it can sometimes be overlooked as a dangerous drug. When a patient is on IV insulin, it's not uncommon to see their insulin sensitivity change quite dramatically as their underlying pathology, nutrition, medications such as steroids and mobility alter during the course of their critical illness. They can therefore end up on a variable rate insulin infusion with rates changing by many units per hour. This can mean that patients go from being on 24 units a day when on 1 unit per hour of insulin to 144 units per day when on 6 units per hour. This is a massive increase, and it's no wonder that blood glucose can crash quickly on such large doses. One way we think that the safer insulin calculator helps with this is by using infusion rates to 1 decimal place, making this jump between values much less steep. We would recommend that any patient who is on an intravenous insulin infusion is identified as part of the morning safety check and highlighted to the medical team for discussion during daily reviews and on ward rounds. Highlighting its use as a high-risk drug will improve awareness and hopefully reduce complications. When patients are on IV insulin, the most common preventable cause of hypoglycemic episodes is failure to monitor blood glucose frequently enough. All guidelines on variable rate insulin infusions stipulate that blood glucose should be monitored every hour when a patient is on IV insulin. Blood glucose can drop rapidly for many reasons, and it's very easy for us to miss glucose checks because of the competing pressures when looking after a sick patient on multi-organ support. Checking a blood glucose every hour takes a significant amount of time during a shift, and it's easy to see why these measurements can get overlooked or delayed. It is, however, essential that when patients are on IV insulin that they do have their sugars checked regularly, and we'd really recommend asking for support from team members if nurses are finding it difficult to achieve this standard. Highlighting this as safety huddles is a good way of ensuring help is available when needed. Patients with subcutaneous insulin will require regular glucose checks depending on their ongoing critical illness, nutrition, and many other factors. Unless advice is given by the diabetes specialist team, we would recommend 3 to 4 hourly checks at minimum when using basal or mixed insulins. We'd also recommend that as part of the daily review, clinicians should discuss frequency of blood sugar monitoring with the bedside nurse and identify factors that might increase the risk of hypoglycemia. One of the big contributors to hypos is the failure to recognise looming hypoglycemia. This is where the blood glucose is in the normal range, but it's falling rapidly and the patient is at risk of a hypo in the next few minutes to hours. As can be seen in the graph here, the drop can be quite subtle, and it's not uncommon for us to fail to recognise the looming hypo if we don't take into account the current blood glucose as well as the previous sample. If the blood glucose is less than 6, our VRII should advise stopping insulin straight away. We would also suggest checking more frequently, i.e. less than 1 hour after that. The risk of a sudden drop goes up when the patient is on much higher doses of intravenous insulin. Historically, one of the big causes of hypos in ICU is when a patient continues to receive intravenous insulin despite an interruption in their enteral feed, TPN, or IV fluid. This can happen for a number of reasons, such as transfers to CT scan, fasting for an operation, displaced NG tubes or failure of IV access. When this happens, it's really important for the insulin to be stopped unless an alternative route of glucose can be administered, and it's essential that blood glucose is checked more regularly and more frequently, and it sometimes may need to be done more than 1 hourly. We strongly recommend following the paradigm of no feed, no need to avoid situations where IV insulin is being given unopposed. There are some infrequent situations where clinicians may wish to start insulin without glucose or feed. These could, for example, be where a patient is in fluid overload or renal failure and is grossly hyperglycemic without an enteral route. When this happens, this should prompt regular review and discussion with the medical team, and when it is practical, starting some background glucose-containing fluid provides a safety buffer against becoming dangerously hypoglycemic. Frustratingly, one of the times when we see hypoglycemia occur is in patients who are starting to make a recovery from their critical illness, start to exercise more, resume a more normal intermittent diet, and are administered less drugs which increase insulin resistance. As these factors increase their insulin sensitivity and we become more relaxed about monitoring, they are more likely to get hypos. In persons who have diabetes that normally take insulin, they are more likely to then start receiving their subcutaneous insulin again. Absorption of insulin can be very unpredictable in critically ill patients, and changes to doses and timings can be challenging. It's important to remember to continue to monitor blood glucose frequently, ideally at least every 3 to 4 hours, but this can be less frequent as patients start to make more of a recovery. It's vital to remember to give subcutaneous insulin at the prescribed times and ensure that nutrition is not interrupted to avoid big swings in glucose and risks of both dangerous highs and lows. The last and sometimes overlooked risk factor is treatment of hypotassium. This is often an urgent and life-saving procedure that involves giving a high dose of intravenous insulin, typically 10 units as a bolus with intravenous 50% glucose. These patients are often very sick, and staff have often got competing priorities when managing them. When we audit hypoglycemic episodes on ICU, it's not uncommon to see patients who have had treatment of hyperkalemia develop a low blood glucose in the following hours, and it may understandably be missed when nurses are prioritising getting the patient onto a hemofilter for their underlying kidney injury. Most guidelines would advise regular frequent monitoring for at least 4 hours after a large bolus of intravenous actrapid and ensure some background containing glucose fluid after the initial resuscitation. Hypoglycemia in critical care is a medical emergency and treatment needs to be immediate and effective. Insulin should be stopped immediately. Most hospital inpatient algorithms for hypoglycemia advocate using intramuscular glucagon and oral glucose as first line. This is a problem in critically ill patients because many have very little glycogen stores, so IM glucagon is unlikely to be as effective, and many of our patients have variable or poor enteral absorption, so oral glucose may be slow to act. As it is essential to treat hypoglycemia urgently, our guidelines specify that if a patient has a central line, then we should administer 50 mils of 50% glucose via that central line. If a patient doesn't have a central line, but does have a peripheral cannula, then 250 mils of 10% glucose can be given safely over 10 to 15 minutes. If a patient doesn't have intravenous access, then 6 glucose tablets can be given orally or crushed down the NG tube. If there is not an established enteral route, then hopefully in this rare situation, IM glucagon and oral glucogel should be given. It is essential that these rescue medications are immediately available whenever IV insulin is prescribed, and the doctor or advanced practitioner should prescribe them as PRN medications at the same time as prescribing a variable rate insulin infusion. Once treated, blood glucose should be checked after 15, 30 and 60 minutes, and we'd recommend completing an incident report to allow monitoring of episodes of hypoglycemia in critical care. Thank you for taking the time to listen. I hope you found this useful. Please remember the following considerations to minimise the risk of harm from hypoglycemia in critical care.